just one of the early examples of it. We're improving radiation therapy techniques. You hear these advertised all the time. And I'm not talking about proton beam because that's a whole other story. But certainly some of the electron beam therapies are being refined and refocused so that you have less damage to normal tissues, more targeted therapy. We're directing therapy to patients who we find from very sophisticated PCR and other tests have minimal residual disease at the end of therapy that you can't see, that those patients need to be treated differently than those who don't have such minimal residual disease by molecular techniques. Whereas we had 4 national clinical trials groups in pediatrics, the Children's Cancer Group, the Pediatric Oncology Group, the National Women's Tumor Study, and the Intergroup Rhabdomyosarcoma Study Group. They've all now merged into one group called the Children's Oncology Group. That means about 240 institutions around the country and in North America and a few in Australia are part of this group. They have a huge patient base, so they can do studies rapidly, except they're also a bit bureaucratic. Because we're improving survival so much with childhood cancer, there are fewer patients who are not doing well. So therefore, thank God, but therefore to do studies to try to see if you're improving from there, you have to get even more patients because the differences are smaller now. So how do you do that? One way you do it is get international studies. And there's a growing number of international cooperative group studies involving COG, the European group, the German group, the French group, even groups in Asia starting to get together and do joint trials so we can pool all of our patients and get these answers better. We're starting to see some work in gene therapy and cancer. I think gene therapy, its application to cancer is going to be very interesting because cancer is a multi-step process. We know that. We know it's not one gene going wrong, that it's multiple genetic pathways that have been disrupted. So gene therapy may be challenging in cancer, but nevertheless, people are starting to develop treatment approaches, and we certainly are seeing, I don't think this should be a question mark anymore, we certainly are seeing effective immunotherapy techniques arising, including both cellular therapy and antibodies and immunotoxins and things like that. Again, the supportive care paradigm has not been silent. New antibiotics, growth factors like GCSF, now platelet growth factors, stem cell support using peripheral blood stem cells to support high-dose therapy, new antifungals and new antivirals, because as soon as you start controlling the bacteria, you start getting our other germs coming in there and trying to make trouble, so you need to constantly be ahead of the game in those. So this has all made, again, this therapy possible. Where are we going to go from here? Well, I think clearly our biggest challenge is resistant disease. Patients who fail, and I'll see this again in a second, patients who fail therapy now are really resistant because they've gotten usually intensive multi-agent therapy up front. When they fail that, they are usually very resistant. And so the key here is to understand better the molecular resistance pathways in those patients. So we can again target those pathways because they sort of a broad blockbuster approach, we're going to try X drug against all patients with resistant leukemia. That's not going to work. We need to be looking for ways of targeting the specific resistance pathways at a molecular level that are causing this resistant disease. We're refining our risk adjustment categories by using molecular markers, as I said, the new molecular genetic information we can get, and we're identifying new targets. And with the molecular data we have, we can now start looking at how we can predict what patients develop late effects and perhaps work on preventing those late effects in those subsets of populations that are at greater risk by understanding that information up front. We are obviously looking at how do some of the treatments we use cause cancer, which is one of the major late effects we can see, second malignant neoplasms in these patients, but also learning more about the pathways of carcinogenesis in the primary cancers and how we might ultimately perhaps prevent some of these cancers. And I would be remiss without mentioning that a lot of the research and the clinical work that's being done in this area is now being enhanced by the incredible imaging techniques that we have. As an example, on the experimental side, There are now ways of attaching fluorescent compounds to luciferase to cells, to malignant cells that you want to study in an animal model. Those of you who have been involved in cancer research know in the old days when you did studies in, let's say, mice, you'd have to sacrifice the mice at some point and look and see what's happened. You don't have to do that anymore. We have imaging techniques that are very specific for malignancies that you can actually follow what's happening with that mouse without having to sacrifice them at all. Actually leave that, observe that tumor over time very accurately in a quantitative manner using these sophisticated imaging techniques. Well, we have similar techniques that we can use, that are being developed now for doing this in patients. And so this is really going to help us be much more exact about residual disease, where it is, where it needs to be treated, et cetera. So that's pretty exciting. Now, moving along, when we talk about resistance disease, I just want to point out that these are the common cancers we see in children, ALL and brain tumors I mentioned. But if you put resistant, even we've made tremendous progress in ALL, if you put resistant leukemia into this paradigm, you see that resistant ALL, despite the fact we're up at 85% or so, still remains an important problem in pediatric cancer because it's one of the most common cancers, so even the 10 to 15% that relapse is not an insignificant number. But here's the data. 80% of children dying from cancer now will have either resistant leukemia or neural tumors, meaning brain, neuroblastoma, or retinoblastoma, mainly brain and neuroblastoma, that group. That's our biggest challenge in pediatric cancer. I mentioned patients who relapse now are going to have much more resistant disease because of all the therapy they've gotten beforehand. Up to now, our approach has been increasing intensity of therapy. The ultimate is high-dose therapy and bone marrow rescue, bone marrow transplant or peripheral blood stem cell rescue. That era is ending, or probably is just about ended. And the reason is that we've reached the limit of toxicity of these agents. You can rescue their bone marrow. Of course, that causes problems sometimes too, particularly allogeneic transplant. But you can't rescue their heart or their lungs or other organs that are now getting damaged by going even higher on these doses. So we've kind of reached the end of more is better, and we really have situations where some pediatric cancers, the side effects of therapy are worse than the deaths from the primary cancer, and I'll show you an example of that in a minute. So our answer is the new molecular technology, which really is going to have to provide us with the information, is providing us with the information to target cancer and cancer cells better and avoid many of the long-term and short-term side effects that limit our current therapy. You also need to know that the worst, and David Fryer is very interested now because he chairs the Adolescent Young Adult Oncology Committee of the Children's Oncology Group now. The worst outcomes in pediatric cancer occur in the older pediatric age range, not surprising, 15 to 19 years of age. The lowest percentage of pediatric patients entered on clinical trials nationally are in the same age range, and there may be a relationship. In fact, there probably is, in part, a relationship there between those two facts. Funding is still inadequate. I mentioned that before when we talked about the numbers issue. Certainly, we are at a lower priority for federal and particularly frustrating is pharmaceutical industry funding. The pharmaceutical industry runs away from testing drugs in kids, particularly anti-cancer drugs. They worry that a drug that might be active in adults will cause some terrible problem in a child, and it'll destroy the use of the drug for anybody, and besides, the pediatric market is so small, there's no profit in it. So they're interested in the adult market, and we are constantly working with them to try to figure out ways to get these drugs studied in children and to get them out to children, even though they're worried about those situations. The federal government helped a little bit a number of years ago when they passed the Pediatric Exclusivity Act, which gives pharmaceutical companies an extra, I think, a year and a half, I believe, or a year and a half of patent protection for a drug if they test it in children. So that has improved a little bit the testing in children, but frankly has not overcome most of the resistance in the pharmaceutical industry.